Okay. Good afternoon once again to everyone who has joined today. Hopefully more people join us. Let's remember to mute our mics. It's a pleasure to have us here today. We'll be looking at a very important topic. The agenda is up, yet we're looking at HAI surveillance, and we have a very seasoned speaker today, Dr. Olufumilola, and she has always been taking us through these topics in the past. And it's a great thing that we're looking at this topic today, looking at everything that is happening in the healthcare system, the outbreaks, the frequent outbreaks that happen here and there. So it's a very, very timely topic. HAIs, they remain a very significant threat, to patient safety, healthcare workers' well-being, and overall, health system performance. And, it's something that we'll continue to look at from time to time. And today, we're going to see that it's not just, about collecting data, but how much are we able to, translate them to actions. And taking us through this very important section is no other person that Dr. Olufumilola, like I mentioned earlier. I'll go ahead to introduce her. She is a senior lecturer at the Department of Medical Microbiology and Parasitology, College of Medicine, University of Ibadan, and a consultant clinical microbiologist to the University College Hospital, Ibadan, Nigeria. She studied medicine at the University of Ibadan. Thereafter, she specialized in medical microbiology at the University College Hospital, Ibadan, obtaining the fellowship of Nigerian Postgraduate Medical College in Pathology. She holds a Master of Science degree in epidemiology from the University of Ibadan and a diploma in medical mycology from the Pasteur Institute, Paris, France. She is interested in epidemiology of infectious diseases, especially in hospitalized individuals. Her research and clinical activities have focused on fungal infections, control of infection and antimicrobial resistance. As an infection control practitioner, she has been a key member of the University College Hospital Infection Control Program for over 5 years. She has garnered experience and expertise from activities in the UCH Infection Control Program, a comprehensive IPC program established over 40 years ago, making it one of the earliest in Nigeria. Domiciled in the Department of Microbiology and Parasitology, the program incorporates routine surveillance of healthcare-associated infections as a major activity to ensure patient and staff safety. She is a coordinator at the annual training course on surveillance, prevention, and control of HAIs organized by the UCA's Infection Control Program. She currently represents the HOD as the UCH IPC focal person. She continues to build her capacity as an IPC practitioner and is currently undergoing the CCAP. Okay, I'm sure she's done, sorry. She has the CCAP's diploma in Infection Prevention and Control Program. She is also a member of the Nigerian Society for Infection Control. It's really a privilege to have Dr. Fumi on today's section. Let's do well to welcome her with our best emoji. And I would love this section to be as yes, so I know that we just have 1 hour for the section, but I would love it to be as interactive as possible. So I would love to indulge each and every one of us to take down our questions, our comments, our contributions while the section is going on. So thank you so much, Dr. Fumi. It's a pleasure to have you here. I would like to say a very big thank you. I've always enjoyed your sections, and I look forward to a very, very productive one today. You have the floor, Ma. You can go ahead to project your slide.
Good afternoon, everyone. Thank you, Mr. Maka, for the kind introduction, and I also thank NSIC for the invitation to present this seminar. As usual, the topic I'm very so much passionate and interested in. And I also welcome everyone. Thank you for joining. I know we are all IPC practitioners, but it's always nice to learn one or two things when we talk about topics like this. So I'll share my screen now and take my video off so that we can have uninterrupted presentation. Please confirm that you can see my screen and it's on PowerPoint. Oh, sorry, on slideshow.
We can go ahead.
Okay, thank you very much. Okay, so good afternoon, everyone, once again. Thanks for joining.
Good
I'll be talking
afternoon.
this afternoon about healthcare-associated infections surveillance. And I know we are all IPC practitioners, at least most of us, but it's always important for us to remember this topic because many of us, we are very busy in our activities, so you may want to just put HI surveillance on the back seat, not really think so much about it. But when we keep on asking ourselves questions like this, it helps us to remember that HI surveillance is important. So as usual, when I talk about this topic, I pose this question to us as IPC practitioners that if you are asked if the annual HAI prevalence or a particular HAI, maybe UTI prevalence, is it increasing or decreasing in your facility? Can you respond to that? Can you actually confidently say whether it's increasing or reducing? If also you have in your facility on a ward 3 cases of MRSA wound infections on a surgical ward, you find a lab diagnosis of MRSA wound infection. Can you actually tell if the infections are related? It points out to the fact that there might be an outbreak on that ward. And then final question, if you get opportunity for funding for the most prevalent HAI in your facility, can you actually say, oh, this is the most prevalent HAI in my facility that you can't fund? Or you have to say, oh, let's go back to the data and check our records to see which one is most important for you to fund. So if we are not able to fully answer that question, then it means that we are not really considering HI surveillance as we should. So in talking about this topic, I'll be using this outline. First, an introduction. What is HAI? What is surveillance? And why are they important? So what's the role of surveillance? Then we go on to the bulk of the discussion, which is actually how we implement surveillance. And in the course of this, I'll give some insights into what we do in my facility. Not necessarily the best, but I'm just practical demonstration of how we implement surveillance in my facility. And then what are the challenges in doing HI surveillance? What are the problems we encounter? And then finally, some recommendations for improving or getting HI to be functional in our facilities. By way of introduction, because it's HAI surveillance, we need, first of all, need to tell ourselves what is HAI. And HAI, also known as healthcare-associated infection or nosocomial infection or hospital-associated infection or hospital-acquired infection, they all mean about the same thing. It's just that it's saying healthcare-associated infection is a more encompassing terminology. So it's an infection occurring during the process of care in a hospital or other healthcare facility, which was not present or incubating at the time of admission, and which may appear after discharge. So you can see that it's not just a hospital. So we don't use hospital acquired of recent, we use healthcare because healthcare can take place in other facilities that are not the classical description of a hospital. For example, you have long-term care facilities, you have dialysis centers where they may admit patients for a few days. So the cutoff is usually 48 hours of admission because we expect that if somebody acquires the infection in hospital, it will require an incubation period of about 48 hours before the infection signs and symptoms come up. Also, the patient may acquire the infectious agent in the hospital, which become evident when they get discharged. So it also includes the immediate post-discharge period, which sometimes we say 1 week, but for some procedures, it may be up to a month before you say, oh, it's not HAI. What are the types of healthcare-related infections? Virtually any part of the body can be infected during the process of care, but the common ones are the ones that are on the screen. So we have surgical site infections, SSIs, also including other skin and soft tissue infections, like somebody who develops a wound infection or pressure ulcer that gets infected on the ward. Pneumonia, the healthcare-related pneumonia or ventilator-related pneumonia for patients who are on ventilators in ICU. Urinary tract infections, catheter UCI in particular, bloodstream infections, mostly central line associated bloodstream infections. Generally, the common infections are resultant from procedures carried out in healthcare facilities or the fact that a foreign body is present in the body, like a catheter or a central line or a ventilator. Impact of HAIs, why are we bothered? They result in long hospital stays. So somebody is supposed to be admitted for 3-4 days, gets an infection, so it gets longer. They are higher healthcare expenses because somebody who has an HAI needs to be treated, and maybe the regular antibiotics may not even be effective, so you need to spend more. Also, higher morbidity and mortality, and some have complications that continue even after the patient has been discharged. And of late, we are particular about HAIs because of the link to antimicrobial resistance. When you have HAIs, many of them are from hospital pathogens that are resistant to antimicrobial agents, and so the infection becomes difficult to treat. Burden of HAIs. So healthcare infections are a global problem. So they occur in all hospitals worldwide, no matter how efficient they are. But the important thing is that you want to limit them as much as possible with your infection control program. So you can see that in the US, they have about 3% prevalence, whereas in Nigeria and other lower in middle income countries in Africa, the burden is as high as close to 30% according to this WHO data, mainly because this the resource limited settings have low infection control processes in place, and they have limited resources for controlling infection. So we go on to the definition of surveillance, which is a general epidemiological expression to talk about continuous, which is very important, is a continuous, that means it's ongoing, systematic, so it's not haphazard, so systematic collection, analysis, and interpretation of a health-related data needed for planning, implementation, and evaluation with public health intervention or program. So that's generally for surveillance. So HI surveillance now specifically is a formal documented system and procedure for identifying, monitoring, evaluating, and reporting the incidence of HAI or related events. So you can see that it's not only the infection that we are particular about, any matter related to infection in the hospital setting, you can carry out surveillance for that particular parameter. So it involves systematic collection, collation, analysis, interpretation, and time dissemination of information that is related to HAI in such a way to guide appropriate action. So we'll elaborate on all this when we talk about HAI surveillance. It's just for us to see the definition of HAI surveillance. A little historical perspective to tell us the importance of HAI for effective IPC. Many of us remember this picture as a history of IPC and even epidemiology generally. This is Dr. Semmelweis, who in the 1800s discovered that obstetric care, patients who were delivering babies were dying. And then he set out to investigate the reason for that fever, puerperal fever, and death in obstetric wards, and realized that those patients were being cared for by nurses, doctors, and medical students. And usually it is when the doctors and medical students care for the patient that they discover that they have these infections. And then it retracts the movements of the doctors and medical students and realize that they came directly from autopsy room to the obstetrics room, whereas the nurses came directly from home, and so they did not bring in any infectious agents. And to complete his investigation, he made recommendation that those who were coming, or everybody coming into the obstetric ward, should wash their hands in chlorinated water, and that resulted in a reduction. It demonstrated all aspects of what we're talking about. You investigate, you find a cure or a therapy, and then you make recommendations for that. So you don't just keep quiet about the therapy or the cure, you talk about it and make sure it's done. So what is the importance of HAI surveillance? It's important for patient safety because we know that HAIs worsen or are a threat to patient safety by all the effects I mentioned earlier. Also, HAI surveillance helps to know where to direct our funds because there's no facility that has unlimited funds. So you want to know, where should we target our funds so that we can have optimal or efficient utilization of our resources. It also results in improvement of the quality of care that you provide for a patient when you do your HAI surveillance and implement recommendations. Surveillance is very important, and you can see that it's one of the core components for effective IPC. And it's a reminder for us to quickly look at it and remind ourselves for the 8 core components for effective IPC. And core component 4 is surveillance. What do we use surveillance data for? When you have your surveillance data, then you can do all this. You can establish baseline data on infection rates. So they can answer that first question that I asked earlier about what are your infection rates. Then you can also answer whether is it increasing or reducing. So you can monitor the trends in those rates for a particular organism. You can also use your surveillance data to detect outbreaks. If you know the baseline rate, then a sudden spike or increase points to the fact that there's likely to be an outbreak. Then it helps you to identify important pathogens that you can target your intervention efforts towards eliminating. Also helps you when you analyze your data properly, you know which units or which areas of population of patients in your facility that you need to focus your IPC interventions on because of the limitation of manpower and resources. You also, want to do your intervention, you use continuous surveillance to see how effective that control measure is. So for HAI surveillance, these are the things you do, the components of your HAI surveillance. First of all, what problem are you carrying out surveillance on? So you need to define that health problem you want to carry out surveillance on. You, after that, need to collect data. So you need to collect your data. After collecting your data, I'll elaborate on all this. It's just a summary of the components. After collecting your data, you need to collate it. So you don't have scattered forms here and then you collate your data. You analyze it and interpret the data in a useful manner. After analyzing, you provide a feedback. So you disseminate the information and then you make recommendations about controlling that particular infection. So now we go on to practical surveillance of HAI, and I'll be talking about facility level. I'm sure we know that HAI surveillance can be done both at the national level and at the facility level. But at the facility level is what this presentation is about. So every healthcare facility should have an IPC program. Remember that is core component 1 of our effective IPC. So they should have an IPC program, and that program should include HAI surveillance. And the implementation should be based on recommendations of the National Center for Disease Control, because that's what our national program on IPC is coordinated. So the recommendation and definitions. However, you need to adapt it to your facility, because you may not be able to follow the recommendations fully, but you need to adapt that recommendation according to available resources in your facility, depending on the type of facility and the size of the hospital. What a maternity center would focus on will be different from what an orthopedic center will focus on, or a general tertiary facility that does everything. The type of patients you have, the resources that you have, funding, whether it's available or not. So what do we need? Regulations and guidelines, human resources, lab capacity, the type and scope, the methods that would adopt, and then the data management processes. So each of the subsequent slides will talk about these headings. So for regulations and guidelines, we need to have clear regulations guiding our data collection, reporting, analysis, as I mentioned earlier. And being under NCDC, this is the Nigerian Manual for Infection Prevention and Control that has various aspects of IPC, including HAI surveillance. So we should all have this as a guide in our facility and then adapt it to create our own IPC program that contains HAI surveillance. We may also use the WHO HAI surveillance documents to help us guide our identification of infections, particularly when we want to define different HAIs. What's our case definition? So your case definitions should follow international standardized definitions adapted to local context. And as I mentioned earlier, you need to consider your limitations. If the case definition says lab confirmed infection, and I do not have a lab, then you may not be able to follow that definition fully. Luckily, we have other definitions that do not require lab testing. So you have standard definition that is based on laboratory results, and they have definitions that do not have lab components. Of course, a more definitive definition will be one that has lab confirmation. Human resources are also important. You need to have identified and dedicated personnel for data collection. It should be in adequate numbers. Remember that for IPC program, we should have at least one dedicated IPC personnel per 250 beds. So if your facility has 500, you should have at least 2 people who are fully dedicated to IPC programs so that they can have enough time for HAI surveillance activities. But we know that many facilities have people juggling multiple functions. So they should be trained, because if they're not trained, then they are not able to identify infections or track infections or even make recommendations if they are not adequately trained. So training would include being able to identify infections, how to limit those infections, and then disseminate the reports. Laboratory capacity, very crucial for accurate diagnosis. We want to have definite diagnosis. So we should have a lab component as part of our HAI surveillance. Of course, the lab may vary in terms of the laboratory capacity. So some may just be a district or a site lab with just a microscope, and we have those with automated or research kind of laboratories that will have the automated systems. What are the types of scope of surveillance? You may decide to do a comprehensive surveillance or a targeted surveillance. In comprehensive surveillance, what you are doing is you are looking for all healthcare-related infections in your facility. So it's usually very resource intensive, because you are looking at every patient to identify infection. So you need a lot of manpower, you need lots of time, and then you need a lot of dedicated personnel. Whereas for targeted surveillance, you want to either select common HAIs or significant organism, or select units of patient population. For common HIs, you may just decide, oh, we want to look at surgical site infections, or we want to look at ventilator-associated pneumonia or catheter-associated pneumonia, catheter-associated UTI or bloodstream infection. And what you select is usually based on your background knowledge about the important HIs in your facility. So if you know that many of the patients are having surgical infection, then you focus, if you don't have enough resources, you focus on surgical infection. If you have an orthopedic hospital, then you may want to think more about wound infection than urinary tract infection. Whereas if it's an ICU, then you're thinking more about device infections compared to the orthopedic hospital. You may also target, apart from infection, you may target organisms in particular. Some priority pathogens like Staph aureus, Escherichia coli, Klebsiella pneumoniae, Pseudomonas acinetobacter are part of what we call the escape pathogens. Escape means that there's a acronym for the first alphabet of the organisms, and also the fact that they escape many of our interventions in the hospital. So they escape antimicrobial therapy, so they are usually resistant to antibiotics. And they include MRSA, multi-drug resistant gram-negative bacteria, ESBL producing gram-negative bacteria, and vancomycin resistant enterococci. So you may just pick those particular organisms because they are the ones that are likely to resist your treatment and may cause problems for the patient. You may decide to select vulnerable patient population or units in your ward, in your facility. So you may pick neonatal units. Usually you pick units where there's a likelihood of an infection. So not maybe a ward where people are less likely to have infections, but neonatal units, intensive care units, surgical wards, obstetric wards are high-risk wards. So you may target those ones if you do not have capacity for comprehensive surveillance. What methods do we use? So it could be active or passive, prospective or retrospective, laboratory-based or ward-based, but the recommendation is a prospective, active surveillance if you are able to do it. So what is active surveillance? Is when trained personnel who are actually IPC practitioners. So IPC practitioners vigorously look for HIs. So they are on the ward checking all the patients, checking records, checking laboratory data. So on a regular daily basis to look out for healthcare information. Whereas in passive surveillance, it's not really the duty of the IPC team, but people just notice, maybe on the ward, the nurses notice that all the patients that had surgery, they are noticing infection, or a doctor notices that, oh, this patient is not supposed to have a particular infection, but we're noticing it in them. Then alert maybe the unit head or the IPC team, oh, please come and check. We are noticing some increase in infections on these units. For prospective, that means you are collecting real-time data, you are observing and noting infections as they occur. Whereas for retrospective data collection, you already have all the records there. Maybe if you have an AMR record, you just go and check at the end of 6 months. So let's even see what are the infections that we've had in this unit or in this hospital in the last 6 months. Retrospective, so that is not very useful because by the time you are checking the records, the harm is done, the infection has spread, patients have had increased morbidity and mortality. And that's why the recommendation is an active prospective surveillance. What about the ward or laboratory based? For ward-based surveillance, you are reviewing patients' records. So you go to the ward, check the records for evidence of infection in all the patients. Look for risk factors. So this patient has UTI. Does he have catheter? How long has the catheter been there? Are there other patients that have the same infection on the ward? So it's simple and cost effective. It may or may not have any laboratory confirmation, but it's quite subjective because you are basing your judgments on what you find in the records. The doctor is saying there's an infection. Whereas for laboratory-based surveillance is quite specific because you are using laboratory data that has confirmed an infection has taken place. So you have accurate data on the pathogen. You're